Cystic fibrosis. It's a hereditary disorder characterized by lung congestion and infection and malabsorption of nutrients by the pancreas. It's an autosomal recessive disorder of chloride and water transport, affecting certain epithelial cells, especially the respiratory, digestive, and reproductive lining. We see dehydration and a thick, tenacious mucus in the lungs and GI tract. The thick mucus is a good medium for bacterial growth, so the inflammation and infection occurs in different body systems. Respiratory failure is the most common cause of death. Clinical manifestations in the respiratory system. Well, there's that accumulation of thick, sticky secretions in the bronchi and alveoli. So the person has frequent upper respiratory infections, dyspnea, a cough, frequent pneumonia, atelectasis, and emphysema. Within the gastrointestinal tract, the thick secretions can cause pancreatic insufficiency. There are inadequate pancreatic enzymes produced with this insufficiency, and that's going to lead to poor fat absorption. It may also interfere with insulin production, and the person may develop diabetes. Further, we see intestinal, hepatic, and biliary obstruction and failure. Within the reproductive tract, the rates of infertility for both men and women are high. There's many different ways to diagnose CF, but the one I want to talk about is the sweat test. Because it's a problem of chloride and water transport, sweat tends to have a high chloride content, and in fact some mothers report their children taste salty when they kiss them. For treatment, for the respiratory treatment, we're doing chest PT, we're doing the vibration, we're doing the percussion, we're looking at medications and perhaps a lung transplant. For the GI problems, we're working on nutrition with them and giving them pancreatic enzymes. Okay, acute respiratory distress syndrome. We used to call that adult respiratory distress syndrome. A lung injury due to the respiratory distress can occur within 24 to 48 hours. This is a disease of severe acute inflammation and pulmonary edema, and it occurs without any evidence for fluid overload or impaired cardiac function. So as we talk a little further, you're going to see this is a disease where there's lots of fluid in the lungs, but we can't look back and say, hey, this person had fluid overload, or hey, their heart wasn't working properly. It's totally separate from that. Okay, here's a chart of what's going on, and this chart is way too busy. So we're going to break it down into 3 different stages. With ARDS, quite often the trigger is some kind of, the person has gone into shock, they've become septic, or they've undergone some kind of trauma. And with that, we see an inadequate blood supply to the alveoli. Either there's just not enough blood supply everywhere in the body, or it's being shunted someplace else. So the platelets aggregate, and we see histamine release, which triggers inflammation. And remember, inflammation, one of the things that happens is increased permeability of the vasculature. So the capillaries around the alveoli have increased permeability. The protein and fluid leaks into the alveoli, and this is pulmonary edema. What do we see with it, or hear with it, is crackles and rhonchi. From there, we're going to see a decreased production of surfactant and also more damage to the lungs. More damage to the surfactant that is present. Because there's inadequate surfactant, we see alveolar collapse and decreased lung compliance. What that means is the person has to work tremendously hard to reinflate their lungs with every inhalation. So they're using all their accessory muscles. We're seeing retractions. The person's having dyspnea and tachypnea, and they're also using a tremendous amount of energy just to breathe. The insufficient oxygen exchange occurs, but we still have CO2 crossing over, even though the alveoli are not working properly. So the O2 is not crossing well, but the CO2 is. We end up with hypoxia. So we're going to see some of the problems of hypoxia in the brain. We're seeing restlessness, apprehension, mental sluggishness. We're also going to see motor dysfunction and tachycardia. ARDS results in respiratory and metabolic acidosis, and death can occur within 48 hours. The mortality rate is 30 to 40%, and it comes from multi-system organ failure in those who don't get treatment. How do we treat it? Well, we try to identify the causative factor and get rid of it. Give them oxygen, perhaps mechanical ventilation to force all those alveoli to open and stay open. We're going to treat the acidosis. We're going to very carefully treat the fluid volume issues. Remember, they may have fluid in their lungs, but that doesn't mean that they've got adequate volume in the rest of their body, so that's a very delicate balancing act. In premature infants, we see respiratory distress as well. However, the cause of it is inadequate production of surfactant. So we see the alveolar collapse and decreased lung compliance. In these infants, we will see grunting. That's where the child is actually It's an end expiratory pressure to try and keep those alveoli open and try and prevent them from collapsing at end expiration. We see nasal flaring, retractions, dyspnea, and tachypnea.